Welcome to MAP, the bi-weekly market access podcast hosted by me, Dr. Stefan Walzer. I am the innovator of Market Access 4.0 and a health economist by training and working in the fields of market access, reimbursement, pricing, and health economics since 2004. Discover Market Access 4.0 and unveil the future with our innovative solutions. Max Insights, our fast and easy AI-based reimbursement planning platform. Dobo, our new revolutionizing way of creating reimbursement dossiers across the globe with the first and only dossier writing AI bot. Cubo, our new AI-based objection handling platform. And Waffle, train with Waffle's virtual reality genius in an immersive environment and with an AI-based counterpart. We are Market Access 4.0. So check out our website, marketaccess4-0.com. And now let's dive into the current discussions, processes, and trends in market access across the globe. So welcome to another episode of the Market Access podcast. Today, I think we have another interesting topic, which is a bit broader than just, let's say, the pure market access discussion we normally have. It's about the social impact of medical innovations. And for that, I'm very happy to have, I would say, a real expert on the topic, who is Ahmed Seddik. And Ahmed, please feel free to quickly introduce yourself in case somebody would not know you.
Thank you very much, Stefan. Great to be with you and such a pleasure to be on your podcast. Before I introduce myself, perhaps just a quick note on my views today. They are of my own. Those are views I gathered from my research for my PhD, and also for the audience's discretion. This is work that I've built and throughout 7 years almost for my PhD, like I mentioned, but with a perspective from the pharmaceutical industry, either as a researcher from outside or as a person who holds a role in the industry. So I'm Ahmed Seddik. I was born and raised in Cairo, in Egypt. I was trained as a dentist, already spent a couple of years working as a dentist back in Egypt. Very exciting time in my career background. Enjoyed it very much, but also at some point I have a very strong calling into exploring broader horizons in domains like public health, international health. And this is where I got to have the opportunity to apply for a master's in international health at the Charité University in Berlin. I was very lucky to get enrolled in this because this was a start of a new journey for me. So this program had a strong emphasis on quantitative sciences, specifically epidemiology and health economics, or at least the track I've taken. But also, as importantly, this program had a very strong emphasis on developing countries. So having myself had the background and having worked in Egypt in a developing country setting with the developing healthcare system, having also had the background in this international health program, really prepared me for the topic of social impact, especially that, and that's the interesting part, where the roles I had in a global setting weren't always related to developing countries per se, but having this backdrop was very important to kind of enable me to understand what social impact really means, what's the counterfactual really. So if an innovation is not reimbursed or is not adopted by society, it wasn't really hard for me to imagine what it would mean if, in terms of foregone societal gains in that sense, because I've witnessed this firsthand in, let's say, patients in a developing country setting who wouldn't have access to existing innovations because of suboptimal coverage or lack of universal health coverage, etc. So this was important for me. And having finished my master's, I started working as a researcher at Weifer Institute in Darmstadt. And at this point, I was very, very well prepared and primed for working on this topic, the social impact of medical innovation. So Weifer Institute is a very interesting, call it think tank or a research institute that combines a lot of sub-teams from different disciplines in economics, including labor work, labor force economics, sports economics, health economics, very different disciplines. And in this kind of setting, you have very exciting, like kind of scientific, intellectual discussions and a lot of cross-pollination across disciplines, which is what informed this very interesting branch of studies into social impact of medical innovation, primarily informed by two things: foundational health economics models, classical cost effectiveness models. So this is the part to measure the health impact of an innovation. But instead of taking this part into calculating incremental cost effectiveness ratios, as you do in a classical cost effectiveness model, for example, Weifer Institute developed a so-called socioeconomic footprint approach, which utilizes macroeconomic methods, very well validated actually, and quite ubiquitously used in the fields of macroeconomics, looking into unpaid work and also macroeconomic spillover effects as measured in indirect and induced effects. So this kind of builds a more like complete image, let's say, or like a broader image of expected societal impact that kind of delivers a validated message, which wasn't in the past kind of applied in health economics. So this was what I've done primarily while I was with Weifer Institute, and then I got enrolled at the University of Groningen in the Netherlands, and I was on a publication track for my PhD. So 5 publications in this field, and then at the end I got some time to reflect on this long journey, 7 years, of which I also held roles in the pharmaceutical industry as a health economics lead from a global perspective for an oncology product, but also afterwards in the cardiovascular and renal metabolic space and early pipeline. So different angles within the pharmaceutical organizations, but always with those layers of backdrop. So, like the contrast between developing countries and developed economies, established HTA markets and universal healthcare coverage versus always like having the ability to imagine versus the counterfactual. What does it mean if an innovation is not adopted? Foregone opportunities and everything. But also, of course, like the background of clinical background versus health economics, public health. So that's kind of perhaps a long background to myself, but also I hope it would be helpful for the upcoming discussion.
Absolutely, perfect. So thanks a lot, Ahmed, for the introduction. And I think it gives already a couple of, let's say, important aspects, especially when we think and discuss about, let's say, the societal impact or the social impact of, let's say, innovation. I would like to maybe do a quick step backwards before we go as well a bit deeper into some of the kind of key things. I mean, from my perspective, what I heard now, and also when I had a look into your thesis, and I think also for me as an economist, it makes a lot of sense. Healthcare spending should especially be seen as an investment and not only as a cost, right? Can you elaborate again how and why that is especially maybe important, and why that might as well be a key driver for the social impact, especially when thinking about a medical innovation? Because I think that's also something important to capture. One, if for example the industry wants to communicate that into the payers world, and obviously two, payers would also need to understand it, because I think also when we have a look on the, let's say, general communication and the kind of public discussion, it's all about cost, which is not 100% true at the end of the day.
Yeah, that's a great question, Stefan. I'll try to unpack it into like separate topics. So I think within your question, you touch on an important point. So to begin with, there is no standard term to define what we are actually at. So is it social impact? Is it socioeconomic impact? Is it societal impact? Is it societal economic impact? There are different terms out there in the literature, and obviously or seemingly trying to explain the same thing in different terminology. So there is, and this kind of as a general theme highlights the lack of consistency in the field. So this is one of the biggest challenges when you approach a stakeholder with a social impact study. Let's stick to this term for now. The first question is, okay, it's very easy to communicate the objectives of a social impact study, and it's also very easy to communicate the results of a social impact study if you monetize everything, and quite comprehensible for people to grasp very quickly. The challenging part really is with the methods. So developing the methods, communicating the methods, and making sure they're actually robust, reliable, and scalable, and also compatible with existing measures, so that whatever you're producing as an output of this analysis is kind of on the same level and compatible with other outcomes. So this is a big kind of challenge in the field, the question of what is social impact and how we define it. And this is something within my thesis I've tried to address comprehensively through a systematic literature review. So really going like a bottom-up approach, scanning the literature of health economics, plugging in all the words that are related, like that I just mentioned, that are synonyms of the term social impact, trying to see how people address this and then building a framework, as I mentioned, ground up, as opposed to like frameworks that come top down from academia. This is the first thing, asking the question of what is social impact and to bring everyone on the same table. And this was really the end goal, as you were saying, because from my work within the industry, I've noticed like that there is an opportunity really to bring those stakeholders that I've mentioned together on the same table. So everyone wants to, seems to, and then that's the interesting part within the pharmaceutical industry. We want to do the same thing, whether we're talking about decision making in the pipeline, so investing in clinical trials and moving ahead with such decisions, or such funding decisions that are made later on from outside the industry, as in HTAs and payers. So the current paradigms in decision making for the latter parties, stakeholders, in that sense, payers and HTAs in established markets where there is a health technology assessment and there are like unified like purchasing powers. I see like some challenge that has stifled the progression of this notion of innovation or it becoming like really the kind of standard practice. And I can elaborate on this a little bit further if you want me, Stefan. And this is kind of one of the main propositions I make in my thesis. So I do propose something called the impact maximization paradigm, and that's kind of to challenge the narrative that we are staying with since, I'd say, the 90s. The field of or the narrative on social impact and societal perspective in economic evaluations didn't advance that much, and in scientific terms has been entrenched in my perspective. So it started in the 90s in the US. You have the first panel on cost effectiveness in health and medicine, 1996, that suggested the reference case of any economic evaluation to adopt a societal perspective. This was a suggestion that came forward very clearly, and it's highly cited. And in spite of that, you don't see this being the kind of the routine way of running assessments, even though we're talking like close to 30 years from this date. I have to say that this second panel has convened, again, like second panel, cost effectiveness in health and medicine in the US, 2016. And in an attempt to advance this narrative a little bit, they kind of proposed a tangible way to measure societal impact. So they proposed the impact inventory 2016. Very comprehensive way of defining impact. They just make sure that if you do it like as a pharmaceutical company, when you're preparing your economic evaluation, you just tick the check boxes like, are we looking at caregiver burden, productivity losses, wider economic impacts, etc., like value of hope, real option value, all the things from also later defined in the so-called ISPER value flower. If you take into account those elements, then you're kind of building a comprehensive view on the value of your innovation in a way that is understandable and accepted essentially by every party sitting on the table. Now, I think, again, like we're almost getting to 10 years of this, and the systematic review that we've conducted as part of the thesis looked into the adoption and the use of those principles and methods and concepts actually in the literature. And it seems that it didn't gain traction though. And again, like I had some time to reflect on this during the discussion, the write-up of the discussion part of my thesis. And this is a good time for me to really get to the basics and really challenge the foundational premises and assumptions within health economics. So what I propose in my thesis in the discussion is called the impact maximization paradigm. And that's kind of a suggestion to move away from a cost effectiveness way of assessing the economic viability of an innovation in the way that, okay, so the science of health economics has evolved to address an important, let's say, problem in economics that isn't solvable if you consider the funding of innovation in healthcare, which is the information asymmetry. So you have the patient, you have the physician, and then you have the payer. And because this asymmetry doesn't exist in many industries, and because healthcare is a very sensitive industry that deals with patients' lives and quality of life and everything, pricing cannot be left to the free market to be determined, and you need like a specialized discipline of economics to kind of help you determine what's a good price. So we already had this moment of reality check within economics, and the decision was, okay, classical economics is not the right way to address health-related funding and pricing questions. We need another discipline. That's good. However, when we look at the cost-effectiveness paradigm of decision-making, we do use the willingness to pay threshold. So just for our listeners as well, very briefly, and in a cost-effectiveness plane, let's call it, you have the x-axis, you have the incremental qualities, the additional qualities you get by a new innovation, and then you have the y-axis, the additional costs you pay for every additional quality. And wherever you place your dot, given like with your cost-effectiveness model, determines and gives the evaluator an idea if your innovation is cost-effective or not. If it in the way it relates to the predetermined willingness to pay threshold. So there is in cost-effectiveness analyses, there is the x-axis that shows the payers basically what's the incremental benefit of an innovation. So in terms of incremental qualities, and the proposed like price or cost on the y-axis. So the incremental cost per quality, and this is where like the paradigm that the payers and HT bodies use to assess if an innovation is cost effective or not, given a predetermined or actually an implicit willingness to pay threshold. So let's say a drug or a manufacturer claims that their new innovation comes at a price that delivers like qualities for one quality for 20,000 British pounds. This will be deemed cost effective. If that's a bit higher, then it's not cost effective, and so on. My proposition is the willingness to pay approach is directly imported from the field of consumer economics, and it places payers in a position of shopping for utilities. So in that sense, we can really easily imagine them as in they just have their shopping cart going around in the supermarket trying to, with the finite budget they have, whether it's 100 euros, 1,000, 1 million, doesn't matter. They won't be able to buy the whole shop. Like they'll have to prioritize, make priorities. And the priorities are, in that case, in this paradigm, they're determined by the patient utilities, individual patient utilities as measured by quality. So it's a setup by definition that doesn't allow manufacturers and payers to engage in an investor-investee discussion, because it's a buyer-seller interaction. How much can I buy from you, and how much am I getting in terms of utilities? And just going one layer, like philosophically deeper to the basics again, the reason I'm challenging this is because health innovation is not consumer goods. Innovation in health, even though being incremental in nature, every incremental benefit you deliver, as in healthcare, it's comparable to breakthrough innovations outside of in other industries. So, and within, like, if you change your phone and buy the new edition, you barely can assume that or claim that you've gained societal impact beyond your individual benefit or utility. Same thing as buying a car or buying a bar of chocolate. But in healthcare, if you have a medicine that doesn't cure a disease, but creates incremental benefit, you'd still expect it to generate a lot of societal impact. And in that sense, what I'm proposing is let's break away from the northeastern quadrant for decision making, have the societal perspective as the reference case in decision making, but instead of payers expecting manufacturers to deliver their economic evaluation and have their dot on the cost effectiveness plane somewhere in the northeastern quadrant, the dot will need to be placed in the southeastern quadrant, because by definition, again, a well-designed pharmaceutical or health tech or whatever, like any med tech device or diagnostic vaccine, anything, by definition should both be cost-saving in the classical terms, which in other terms mean generates value to the society, to the payers, to everyone, but also generate value to the patients. And if this view is adopted, then decision-making will look different, and the relationship between the manufacturers and the payers will also be very different. And just to bring the whole discussion full circle, this will allow stakeholders, in that case, patients and payers, to approach the decision-making in the same way a shareholder actually approaches, which is, I want to maximize the societal benefit with my investment. So whether I'm investing as a shareholder in a company, that I want to make sure it doesn't only maximize my profit. I want it also to generate social impact, and this is important nowadays for investors and shareholders. This becomes equally important for payers as decision makers much later on in a product life cycle, and then makes the social impact a topic that kind of brings those two worlds together, as you mentioned at the beginning, Stefan.
Yeah, no, I think that's a very good point. And I mean, we see, let's say, or I would rather say, and you're the expert, but I would generally say that I think we see some of that, which has maybe already been a bit more implemented in some of the Scandinavian countries. But I think also the values itself, also from a cultural perspective, are probably already maybe anyway, I would say a bit more broader for a social impact. Having said that, I would still want to maybe challenge you a bit on what you said. And as an economist, I'm totally with you. But when I would be thinking about different budget silos, what we know from a lot of payers across different jurisdictions, is this maybe not too broad to implement? Meaning, do payers really have the power, even if they would understand the method and the impact of it, versus maybe a bigger change, which would maybe need to happen at a political level?
Yeah, that's a great point. And actually, it's also great that you mentioned the application of this in the Nordic countries, because those are countries that kind of like fall in this category where they, in a way, acknowledge the importance of reflecting the societal preferences in decision making. So it's the payer perspective doesn't necessarily reflect the societal preferences, and this is an important point. And the way they decide is that they still, like in the most part, use their reference case or base case in which they have a payer's perspective or healthcare system perspective, and run a supplementary analysis like to look into the societal perspective, and then based on this, back into their base case, if there is like a case for a high societal impact, would be open to, like push their willingness to pay a little further. So it's not a standardized way. Bring us back to the discussion. Is this like a really a welfarist approach, a quantitative approach, something that's makes it easier for manufacturers to gauge, like this is what manufacturers want. They want certainty in the frameworks that they'll be evaluated against. This approach doesn't provide this though, so it leaves it open. So when is societal impact enough, when it's not enough, and so on. But acknowledging this point and also acknowledging the fact that, of course, payers do have short budget cycles. They have their own way of doing things, and long-termism is not doesn't become like top of mind or important for their decision making, and that's where we need to find practical solutions to marry like those two worlds. And in my proposal here is it's really like the impact maximization paradigm, breaking away from like a buyer-seller interaction and just utility maximization. It's not about only utilities for individual patients. It's more like the societal perspective and societal impact. And also important to note, like over the years, we're also now in the age of big data, AI, like RWE. So it's becoming less and less of a challenge to generate frameworks and methods to deliver a standardized way of measuring impact. And that's what I've also tried to show in my thesis, like a standardized way to measure impact across disease indications, across different populations, etc. So it's possible. But now it's the time really to, like you're saying, go back to the basics, see what are the foundational challenges for payers and what really stifles this paradigm shift from short-termism thinking into long-termism. Because again, payers need to reflect the societal preferences. That's very important. And short-termism, I would argue nowadays is not really how the society thinks. Society wants like long-term outcomes, and this is important to be reflected in decision making.
Yeah, no, I fully agree. I mean, obviously, it is very complex, right? When you think about the various healthcare systems, I think you have rightly mentioned, let's say, the healthcare generally, or the healthcare market is obviously, let's say, a difficult monster, having information asymmetry, moral hazard, etc. Even though that there are at least some areas, maybe especially the US, where they would generally still think, some, not all, right, but some would still think free pricing there is still the right way to go. If I agree or disagree, is maybe one thing. But what I want to maybe add let's say, is the complexity. I mean, I like the way how you basically put everything together. I like as well how you basically explain that payers need to go away from, let's say, shopping for utilities. So would this be your approach? Would this be rather something especially applicable to countries where, for example, cost effectiveness is already, let's say, applied? So it's maybe not the US, it's maybe not Germany, but it's rather UK, Canada, Australia, a couple of other European countries especially? Or would you rather say, what I could also understand is that the whole kind of impact from a societal perspective is much broader than just the pure cost versus effectiveness? I do not want to say cost effectiveness, but it's just taking both, let's say, part of the equation into account. So what are your opinions on that? And then very briefly as well, how would potential steps look like in order, and you mentioned some of that already, in order to, let's say, start such an implementation, at least in a short term where we know it might take a bit longer?
So, I mean, it's the problem that you described is already well characterized and explained in the literature. So the fact that, like, let's say you call them cost effectiveness markets, like the UK, Canada, Australia, and so on, they follow a so-called welfarist approach in decision making. And in that sense, utilities, individual. So the main assumption is the value you get as a society is comprised of the sum of the individual utilities. And this is what you get from a qualis-based approach. So other markets like Germany, for example, and France, they kind of acknowledge the limitations with this approach because there is the extra welfarism, as it's called, that there are the value elements that are not captured beyond. So we are all like in a universal healthcare coverage system in Germany. We the payers represent us as like individuals that fund this the healthcare pool. So as a society, we do care about others getting healthier if we're not the main beneficiaries of at least for now from a certain funding or coverage of a drug. So the extra welfarism actually claims that there is value beyond the individual patient level that goes to society, either in form of improved productivity, improved efficiencies in the system, actually utilities both for caregivers in that sense, or actually just neighbors, community members, from seeing friends and family and other members of the community being healthier. If you follow a quality-based approach, a welfarist approach, you're not capturing this. And this gives rise to the decision makers approach in decision-making in Germany, as an example, in France. You can argue a decision-maker approach is arbitrary and it's not as transparent as a welfarist approach. And this is where my suggestion really comes in, by saying, okay, let's stay with the welfarist approach, but let's broaden it in a meaningful way and use take advantage of the existing computational power and statistics and AI and everything and the data, and broaden the perspective. So that's the practical take on your question. Now there is the political part of it. Really is really like you have those silos. You have like payers. They're comfortable with their budgets and everything, and this requires a serious political engagement. And again, this discourse on social impact would essentially has the ability to bring more stakeholders to a table, because eventually if you are able to monetize the impact, then you make communication very easily across different stakeholders. You bring a wider set of stakeholders to the table. Finance ministries, also patient group, and so on and so on. So a wider set of audience and stakeholders than you're used to have in classical decision making in those countries that you've mentioned that follow a cost effectiveness approach. So I think it's just one way to advance the narrative. Like I mentioned, it's been entrenched for quite some time. You visit conferences, it's a standing topic on every international conference for decades now. Mm-hmm. And the progress is very slow, in my opinion. And we need to really dig back to the assumptions. Maybe they're useful at some point, but we need to start thinking in a broader way. And the first thing to do is just find ways to bring more stakeholders to the table. The end goal is to, of course, have patient centricity in every decision making, but also, as importantly, I'd argue, is to reflect the societal preferences in the decision making, which has not currently happened with the shift towards long-term thinking for the society.
Mm-hmm. Perfect. No, Ahmed, that was great insights into a into a very broad topic. I mean, it covers basically policy, health policy, obviously, economics, economic theory, macro health economics. So it's really, really interesting. And obviously, we could have even spoken probably a couple of hours longer, because I would have still had a couple of more questions on it. But I mean, the idea is always to, let's say, have somewhere around 30 minutes that people can really follow it. But I would highly appreciate as well, obviously, for everybody who's interested in the topic. I mean, get back. And I think the thesis, Ahmed, is available. Freely available, so people can really read it as well. I mean, it's a really good one. It's heavy sometimes for people maybe not too close to economics, but it's something I would really appreciate. And as you have as well just said, the implementation is maybe on another side, but maybe we need to really push that through and just keep in mind, sometimes things just take long. Think about European JCA, where I think I still remember when I started in the industry. That was the start of those discussions. That's already more than 20 years ago. And just this year, the whole thing has maybe started. So maybe we will still sit here in a couple of years, maybe 10, 15 years, maybe just look back and just think, you know what? That was the time where it was basically ramping off, right? And now it's being more broadly implemented. And maybe some of the countries already using a bit of a broader perspective might implement it first. So I want to thank you. That was really great. Thanks for your time. Thanks for your insight, Ahmed, and talk to you again soon.
Likewise. Thank you very much, Stefan. Great to be here.
What an interesting and insightful expert interview this time, which was more from an economics perspective, from an economics theory perspective. However, what has as well been discussed probably more towards the end of the podcast session was especially, let's say, the applicability, because obviously we all know, and we mentioned that some countries maybe have a bit of a bigger societal impact perspective with what we see basically in some of the Scandinavian countries. We have also different jurisdictions and methods which are being applied for reimbursement purposes, such as incremental cost effectiveness, which is included in the portfolio of the decision making, like the UK, like Canada, like Australia, like some others as well. And we have as well the very much other extreme like the US and a couple of other systems in between. I mean, how to implement within all of those systems such a kind of broad perspective needs to be seen. I think there needs as well to have a political will to implement that. But at the end of the day, and that's where I'm pretty much sure, maybe it's not so much about the pure method itself, but I think at the end of the day, if decision makers as well as industry would really have a bigger look on the societal impact. So it's not only the drug cost and maybe the direct medical benefit on a given patient, which is the key driver for sure, then we might even maybe see that kind of impact in the next couple of few years. That was an episode of MAP, the Market Access podcast provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. MAP is available every second week with a new episode, so watch out. And in case you might have questions, contact me directly and or visit our website on www.marketaccess-pricingstrategy.de.